Hello everyone, this is Dr. Garima Sachdeva, one of the mentors of study in RCOG, and today's topic of discussion is a recent talk released in 2022, and the topic of the talk is opioid misuse in pregnancy. So what is opioid use disorder? So according to DSM-5 manual criteria, opioid use disorder is identified when there is a problematic pattern of opioid use leading to clinically significant impairment or distress, which is manifested by at least two of these criteria. I'll just read them within a 12-month period. So it should include two criteria within 12-month interval. So the first one is opioid is taken in larger amounts or over a longer period of time than it was intended. There is persistent desire or unsuccessful efforts to cut down or control the opioid use. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid, and recover from its effects. There is craving or strong desire to use these opioids. Recurrent opioid use results in failure to fulfill the major role or obligations at work, school, or home. There is continued opioid use despite having persistent or recurrent social or interpersonal problems. Important social, occupational, or recreational activities are reduced. Recurrent opioid use in situations in which it is physically hazardous. Continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by that. Tolerance. What is tolerance? It is a need for markedly increased amounts of opioids to achieve intoxication or desired effect, or a markedly diminished effect with continued use of the same amount of opioid. So either there is increased need to have that desired effect, or if they are taking the same dose, the desired effect is less. What is withdrawal? It is the characteristic opioid withdrawal syndrome. Opioids are taken to relieve or avoid withdrawal symptoms. So basically, there are various symptoms like sweating, anxiety, and the patient has to take opioid to relieve those withdrawal symptoms. So severity of opioid use disorder is classified as mild, moderate, severe. If there are 2 or more symptoms, these are the symptoms, then it is called mild. If it is 4 or 5 symptoms, it is called moderate. If it is more than 6 symptoms, it is called as severe. Then, what is opioid substitution therapy? So according to NICE, you can use either methadone or buprenorphine as a opioid substitution therapy. And why is this used? To reduce or stop illicit drug use and is associated with risky behaviors while helping to prevent withdrawal symptoms. So these methadone and buprenorphine, they stop the opioid use and prevent the patient from withdrawal symptoms. So they don't feel the desire to have more of opioids. So it helps in overcoming the dependence on opioid. Then according to NICE, outside pregnancy, you can use, both of them are equally effective, methadone and buprenorphine. However, during pregnancy, methadone is better than buprenorphine. In case of buprenorphine, risk of fatal overdose is lower and withdrawal symptoms are less severe. For methadone, it is effective in patients and basically retaining the patients in treatment, and it is more suitable with a history of intravenous drug abuse or more severe opioid dependence. And when you are using this methadone or buprenorphine for induction of treatment, it takes usually 4 weeks and it is followed gradually by the maintenance dose. Now coming over to opioid misuse in pregnancy. What are the maternal effects? There are direct and indirect effects. Direct effects include amenorrhea, oligomenorrhea. It basically provokes spasm of the smooth muscles and causes uterine contraction. So there is increased risk of preterm birth, preterm labor, and fetal growth restriction. It causes abnormal cardiotopography in the form of it causes fetal bradycardia, decreased variability, and decreased accelerations. However, no increase in congenital malformations have been noted with opioid misuse. Then coming over to the indirect effects, There is erratic dietary patterns, unstable living conditions, unemployment, and coexisting mental health issues. So, as a result, there is lower pre-pregnancy starting weight. There are psychiatric problems like depression. Long-term users, they are vulnerable because they are using injections, so they are vulnerable to blood-borne infections, thromboembolism, and organ disease. There is risk of bacterial endocarditis, thrombophlebitis, pneumonia, bronchitis, syphilis, tuberculosis, abscess formation, and cellulitis. And needle sharing, it raises the risk of hepatitis B, C, and HIV. Now, coming over to neonatal effects. So, if the mother is dependent, it also causes effects on the newborn, and this is known as neonatal abstinence syndrome. So, when does the infant manifest with these? 55 to 95% of the patients, of the neonates which are born to a mother who is opioid dependent, they have symptoms of this neonate abstinence syndrome. And what are the symptoms? It causes respiratory distress. There is CNS symptoms like increased tone, high pitched crying, sleep disturbances, tremors, irritability, seizures. There are GI side effects like poor feeding, vomiting, regurgitation, diarrhea, weight loss, excessive sucking. Autonomic problems include fever, yawning, sneezing, sweating, mottling, and tachypnea. These symptoms usually present within 24 to 72 hours of the birth in around 75% of the cases. Actually, it depends on the half-life of the opioid. So, in cases of heroin, they present within 24 hours. In cases of methadone, which has a slightly longer half-life, they present within 3 days. And buprenorphine, which has an even longer half-life, they may take longer to manifest. Neonatal seizures are also rarely seen in 5% of infants facing neonatal abstinence syndrome. Now, coming over to antenatal care, an MDD team, including all these consultant obstetrician, specialist drug and alcohol midwife, community drug and alcohol services, GP, health visitor, safeguarding lead, social worker, probation, and housing officers should be involved. And clinics should be consultant led with attendance from other specialities like drug and alcohol services. So, apart from the routine screening of HIV, hepatitis B, and syphilis, in these patients we should also do screening for hepatitis C and also offer them urine toxicology, which should be performed at booking for women who say that they have been using the drug, and again they should be repeated during the pregnancy who continue to use them. And on these opioids, basically they are eliminated from the urine. When you're testing for the urine toxicology, opioids are eliminated within 48 to 72 hours. And the patients who are abusing other kind of drugs like cannabis, their elimination time is around 30 days. So you can, with using urine toxicology, you can detect what all drugs a female is abusing. So you offer them opioid substitution therapy. As already discussed, in pregnancy, methadone is preferred to buprenorphine. These patients also face depression, so they are usually taking SSRI. So in patients who are on SSRI, there is risk of increased congenital malformation. So they should be offered fetal cardiac scan. So the various physical, psychological, lifestyle issues encountered with the opioid misuse during pregnancy are discussed here. So there could be nausea, vomiting, which is common in early pregnancy. There could be dental infections. There can be issues regarding IV drug abuse. Mental health issues are there. 40% of the females suffer from mental health. They are on SSRI and they should be screened. Neonatal screening should be done because of the risk of congenital malformations associated. These females are at risk of domestic violence, smoking, financial accommodation issues. All these issues are faced in the antenatal period by the female. Then intrapartum care. So intrapartum care, many drug-dependent females may opt for an epidural during labor, and they should be given that. Pethidine usually is not effective in these patients who are opioid dependent because of the changes in the opioid receptors. These patients should undergo continuous CTG monitoring during labor because of intrapartum hypoxia, fetal compromise, and meconium staining. These all risks are increased, especially in women with placental insufficiency secondary to drug abuse and pregnancy. In neonates who are born with respiratory distress, you should not give them naloxone because it causes abrupt withdrawal and then it worsens the condition of the neonate. So you should not give them naloxone. You should let the pediatrician manage the respiratory depression. Then postpartum care. So if the mother is opioid dependent, obviously they would not benefit with lower doses of analgesia or opioid, so they always require higher analgesia. So if it's vaginal delivery, it can be managed with NSH. However, in LSES, you have to give short courses of oral or IV opioids in addition to the patient's maintenance dose of substitution therapy that you're giving, methadone or buprenorphine. So if it is used morphine in correct doses for short-term pain control post-delivery, it is safe in breastfeeding. Regarding neonate should be kept in the hospital for at least 72 hours following birth, and they should be monitored for neonatal withdrawal symptoms, first every 2 hours and then every 4 hours thereafter. Breastfeeding should be continued. Even these methadone and buprenorphine which are given, they're transmitted in very low quantities in the breast milk, so they are considered safe during breastfeeding. So this was all about this talk. Thank you so much.